Hello, everyone. Welcome to the Hot Topics Mentor Session, the 26th anniversary of our Alamo Advocate Program. We've been doing this 26 years now. Anyway, just want to cover some housekeeping items first. If I can have everybody make sure that your phone is on silent, please, please make sure your phone is on silent. And I would also ask that we're going to have questions at the end. I'm going to introduce our panel here. We're going to have some discussions about the hot topics for the day, and then we'll open up the floor to questions from the audience. I would also ask that when you ask questions, in the end, let's please keep it questions related to topics that were presented today. Don't ask questions about your personal medical history, personal medical concerns for a variety of reasons, but let's please keep it kind of general. Anyway, at this point, I'd like to introduce our panelists here. First, I want to say thank you to our sponsors, of course. Without their financial support, we would not be able to put this program on, again, for 26 years now. So please thank our sponsors. I want to thank our Alamo Advocate Planning Committee. I know firsthand how much work goes into putting this program together. It is a year-long process, and it's amazing. Oh, great. And it's a real challenge, but we love doing this, and it's an amazing program. So anyway, first things first, let me introduce myself. My name is Jonathan Colmier. I'm a past president of the Alamo Breast Cancer Foundation, former executive director, and former Alamo Advocate Program chair. So anyway, at this point in time, I want to introduce our panel. I'm going to let them kind of give a bio on themselves, but I just want to introduce them. Dr. Debu Tripathi. Tripathi, did I get that correct? Tripathi.
That's right. You got
it. Dr. Mankoff, Dr. Chan, and Dr. Virginia Kaklamani. Thank you. So, Dr. Tripathi, if you'd like to introduce yourself.
Well, thank you, everybody, for being here. I'm Debu Tripathi. I'm a breast-focused medical oncologist and also involved in clinical trials. I'm the chairman of the Department of Breast Medical Oncology at MD Anderson. And I've always appreciated a chance to communicate with patients, with advocates. You all do great work, and I hope I learn as much as all of you do from listening to my colleagues and hearing your questions.
Dr. Mankoff?
Dave Mankoff from University of Pennsylvania. I am an imager, a molecular imager, nuclear medicine physician, and I've been a Komen Scholar for a while and working on breast cancer for almost all of my research for many years. I did my first one last year, and I think I want to quote Sally Fields, "You must like me. You invited me back." So thank you. This is a really wonderful program. And for those that don't get enough imaging tonight, there's actually a dedicated molecular imaging lunch and learn tomorrow. So I'll try not to cross over on those topics too much, but I'm really delighted to be here and have this much interest in our topics.
Great, we appreciate that. Dr. Chan?
Hi, my name is Isaac Chan. I'm an assistant professor at UT Southwestern. I feel very honored to be on the same stage as these giants in the field. So I'm a physician scientist. I see patients with breast cancer, but I also run a lab. And my lab focuses on how we can activate someone's immune system to treat metastatic breast cancer and breast cancer in general.
Great. Dr. Kaklamani?
And I'm Virginia Kaklamani from UT Health in San Antonio. I guess I had the shortest trip here this time. I've been doing this program since 2005. And this has always been the highlight of SABCS for me. So thank you for all being here. Thank you for keeping our priorities straight. Thank you for everything that you do to help our patients and to educate us as well. So an honor.
Great. All right, well, let's jump right in. What sizzled today, Dr. Tripathi?
Well, to open today's first session was a presentation on a new antibody drug conjugate. And don't ask me how they get these complicated names, but datopotamab deruxtecan. We call it Dato-DXd for short. And some of you may be familiar with the concept of antibody drug conjugates. These are drugs that are a little more targeted than just giving regular drugs or chemotherapy drugs, in that they have an antibody that guides them to tumor cells. So the antibody needs to be to a protein that is specific to tumor cells. And when antibodies bind to a receptor on a cell, they tend to get internalized. It gets brought into the cell, and it brings along with it the chemotherapy that's attached to it by a linker, sort of like a Trojan horse. When it's in the cell, the chemotherapy gets released and kills the cell. And the chemotherapy can sometimes get out into the tumor area and knock out other cells as well. So the goal is to actively kill cancer cells while having less of the chemotherapy circulating around the body to have fewer side effects. And these drugs, when they were initially developed, were somewhat effective, but still had toxicities, and they've refined it. They've gotten a little bit better. So this particular drug was tested in patients who, with advanced breast cancers that were hormone receptor positive and HER2 negative, and they had already received a hormonal therapy or 2 courses of hormonal therapy and also received a chemotherapy, but were now having progressive breast cancer. And they were eligible to be on this trial that compared Dato-DXd to one of 4 different chemotherapies that are commonly used in breast cancer. And this trial did, in fact, show a greater degree of response and progression-free survival, how long patients went before the cancer progressed. It was about a third longer. So it's an improvement over what we would see with standard chemotherapy, but also a new antibody drug conjugate that may be better tolerated. When they looked at the side effect profile that patients experienced and the number of people that had to come off due to side effects, it was better with the Dato-DXd. So this is going to be another tool that we have. There are 2 other approved antibody drug conjugates, one called trastuzumab deruxtecan, also known as Enhertu, which is specifically for HER2 positive or HER2 low breast cancers, and then another one called, you're going to love these names, sacituzumab govitecan, or SC, and it's effective as well. Now, we have a research program going on at MD Anderson where we're trying to personalize these antibody drug conjugates, and I think this is going to be the next step, where we know what antigens are expressed on the tumor cell, and we have several antibodies that we can take off the shelf and then conjugate it to a chemotherapy drug that the patient has not been exposed to before, so because they may be resistant to the other one. So this would be more customized. And then the next generation of these are going to be antibodies that are bound to a biological drug instead of a chemotherapy drug, a drug that works better when it's internalized into the cell and can directly act on one of the organelles or some other aspect of the cell in which it induces damage or death to the cell, but without the side effects of chemotherapy like other biological drugs. And I think that's when we will really start to make some better advances that are more meaningful. So I think this is a step in the right direction, but we've got a ways to go.
Excellent. Dr. Mankoff?
So last year when I was here, I focused on the imaging spotlight session we had last year, which was really focused on screening, detection, and the development of artificial intelligence techniques to help you get more out of your images. We again had an imaging spotlight, and I want to thank Virginia and others that have been involved in the program for being able to feature it this way, which was really actually quite different. And this year was a little bit closer to the area that I work in, and it was a spotlight on molecular and functional imaging. And it moved away a little bit from pure detection to number one, a focus on more advanced disease, locally advanced disease and metastatic breast cancer. But it also focused not only on identifying sites of disease, but being able to identify targets. And I want to follow up on what Dr. Tripathi said and how we might use these. And also to evaluate response to therapy. So this begins to enter an era that's been starting to come in more into play, is that imaging is not only a way to find the disease, but help guide people who are making treatment choices on what types of drugs they might use and how effective those drugs would be in a more powerful way than we've been able to do before. In the first half of the session, we had 4 investigational agents. The imaging contrast agents are themselves drugs, and all of these were investigational agents that were being studied under IND or similar regulations. We actually had 2 focused on HER2, and one of the HER2 agents, which is called zirconium-89 trastuzumab. Zirconium is a metal and it's an isotope, is basically labeled Herceptin, if I'm allowed to use the trade name. And so the idea is this imaging agent can identify in metastatic disease the tumors that contain that target. And so one can conceive not only of using this to direct trastuzumab therapy, but in those antibody drug conjugates where the antibody is trastuzumab, this holds a great deal of promise for being able to guide and evaluate that treatment. But a very interesting study looking at the heterogeneity of expression based upon that, which is a key factor in predicting whether or not you're likely to get a response at all sites of disease. We had another very interesting paper that was based upon an MRI agent, and this was a landmark study because almost everything we've done with so far is PET. For good reasons, it's a well-suited modality, but the idea that you could begin to use targeted agents selectively in other modalities, such as, for example, MRI, was very exciting and was a very early paper. Another paper that was come to us, which has been very popular lately, uses a labeled imaging agent called FAPI, and this is fibroblast activated protein inhibitor. This is an interesting topic that's come up recently with the discovery that tumors have their own series of fibroblasts, that they have stromal support of the infrastructure around them that is somewhat specific to tumors. And so there has been the ability of PET agents, largely in Europe, but now in the US under investigation, to have imaging agents targeted at these fibroblasts or stroma. So it's a very interesting idea to not only detect the tumor itself, but perhaps to detect the tumor by their association with abnormal support structure in and around the area. These provide very high contrast images, as we saw in the presentation, and are an interesting topic that needs more study, but is a new way of thinking about identifying cancer and maybe finding out whether or not it's gone away after treatment. The last of the new agents that I want to say in full disclosure I'm involved in commercializing is a labeled PARP inhibitor. For those that haven't heard of this before, PARP inhibitors are a drug that are used in association with women that have BRCA-related tumors, and it gets at the susceptibility of those drugs because they've lost one of their DNA repair mechanisms. This labeled agent has been shown in very early studies to add predictive value to the genomics that is part of the assay for the PARP inhibitor. And in this study, there was very early data coming from my institution, the University of Pennsylvania, suggesting that it might also be predictive of response to DNA-damaging chemotherapy. Again, needs more study, but very early information. In the second half of the study, which I'll go through a little bit more quickly, we had a number of modalities, contrast-enhanced mammography, contrast-enhanced MRI, and the approved agent, fluoroestradiol, an estrogen imaging agent that's been on the market for a while, used to talk about how to take care and identify things that are important for treated patients. One was the follow-up of patients who had contrast-enhanced mammography. This is a really interesting idea. By using the same contrast you get with a CT scan, you can have many of the same properties that you get with an MRI, but with much simpler technology. It was a very exciting paper that might be helpful for follow-up of patients who have had former breast cancer. And much of the rest of this was about using contrast-enhanced MRI in patients undergoing treatment before surgery, neoadjuvant treatment, and then the same thing using the estrogen receptor PET to be able to make evaluations, and in some case relatively early in the course of the treatment, how likely the treatment success is likely to be. And if we can identify futile therapy within the first few weeks after going that we're not likely to have a good response, then we have a choice to be able to think about other agents and design studies to test the value of that approach. And I think it was an indication that these tools for early evaluation are finally here. So very exciting science going on, very different than what I talked about when I came here last year, and really filling out the full portfolio, I think, of what imaging has to offer.
Great. Thank you. Dr. Chan?
Yeah, I mean, I actually found those summaries very exciting. You know, I want to follow up on something that Dr. Tripathi mentioned with the Dow to DXD study. But I first wanted to mention that one thing that really excited me about that study was that they actually mentioned, Dr. Bardia mentioned, kind of quality of life. And I thought that was really nice that he put that into the presentation. And they measured time to deterioration versus chemo. And they showed that patients, not just focusing on metrics of grade 3 or grade 4 or even grade 1 and 2 adverse events, but actually measuring quality of life and how people are scoring that compared to the chemotherapy arm. And so I thought that was a very nice addition to the presentation. One thing I do think in this ADC space that will be very important, and this is where my lab has also been doing active research, is trying to identify biomarkers, like Dr. Tripathi was mentioning. So I thought Dr. Lippman had asked a very interesting question at the end of the presentation about, TROP2 as a biomarker for Dato-DXd. And then, I think the response was that we don't really have good biomarkers. We don't know yet if antigen presentation, if expression of TROP2 as a biomarker is indicative of therapeutic response. We don't know the temporal expression of TROP2 and whether that fluctuates during therapy. And then we don't necessarily have good surrogates. So, coming off of, for example, cell-free DNA as a potential surrogate biomarker for efficacy of these ADCs, there's a lot to be learned in this space. And then I think, as you're kind of reflecting a little bit further about, when you might clinically use Dato-DXd, in terms of sequence of ADCs, a lot of these patients were heavily pretreated before, but they might have received sacituzumab. They might have, if they were HER2 low, they might have received Enhertu or trastuzumab deruxtecan. And so where would you really sequence Dato-DXd in the lineup of ADCs, I think is a really interesting question that we're looking to explore, or the field is looking to explore. And then finally, I think, what is a little bit understated about ADC and in terms of antigen targets is the role of the immune microenvironment, or the microenvironment in general, and how it can impact antigen presentation. So, and this is work that my lab has done, where we developed a method called InteractPrint that allowed us to dissect out the heterogeneity of tumors. And we think that's very important, because tumors are made up of very heterogeneous components. And those heterogeneous components interact with the immune microenvironment, or the microenvironment in general, in different ways. And what we found was that the microenvironment can actually shape the antigen presentation that's seen on these different heterogeneous cancer cells. And so I think that's actually an area of understated exploration. Something that we should be thinking about is what, we're all focused on, how the antibody binds to specific tumor antigens that are expressed. But I think it'll be really interesting to see how the tumor microenvironment actually shapes those antigens, and how that might contribute to resistance, and that could also contribute to the development of new ADC targets. So that's what I found very interesting about that first session. So, very excited to see the data.
Awesome. Hey, Dr. Kaklamani.
So I'll mention a couple of things, and I'm not a surgeon or a radiation oncologist, but we don't have one on the panel, so you're going to have to rely on us for some of these abstracts. But one of the most important parts of the whole meeting was a session today on local therapy. And we've been all talking, especially medical oncology, about giving more and more and more therapy. And our radiation and surgical colleagues are talking about de-escalating, doing less and less and less and less, which is really good to see. So there were several trials that looked at a couple of different things. One is, should we do axillary node dissections in patients that have some node positivity, or should we just stay with sentinel lymph node biopsies? And we had data in the past showing that doing sentinel node biopsies is probably safe, and we don't need to remove a lot of other lymph nodes. And there was some data today from the Sonoma trial that confirmed that, and showed that we doing more surgery and removing more lymph nodes doesn't really help a woman live longer, and it typically actually increases the chance of lymphedema and a lot of other issues that unfortunately come with doing more extensive surgeries. And then on the radiation side, there was a wonderful trial called the IDEA trial that married the thought of not doing radiation with a genomic profile of the tumor. And so what they showed was that in women that are aged 50 to 75, if we know that the tumor has good characteristics, it's not a very aggressive cancer, those women, we may actually be able to avoid radiation altogether. And obviously, we know that nobody wants to be going and getting radiation if they don't have to, because radiation can be associated with other side effects. And we knew that in women over the age of 70, it was probably safe to avoid radiation, but we didn't have a lot of data in women under the age of 65, and now we do. And so this really opens up a whole new thought process for our patients that can now make a good decision as to whether they think they should go and have radiation or potentially avoid it. And I think those were really nice studies in showing that instead of trying to think of what should we do more, sometimes we should think of what can we do less without compromising our results. So that whole set of abstracts, I think, was really interesting and hopefully will lead us, again, thinking more about what we should be offering our patients and giving you all options to consider. And then the other trial that I thought was pretty fascinating was exercise. And we've talked about exercise in patients with early stage breast cancer, and we know all of the benefits, and not just the benefits on physical activity and feeling better, but also benefits on tolerability of our medications. But this was a nice trial in women that had metastatic breast cancer. And they offered exercise. And these women, some of them had pain, some of them had fatigue, some of them had shortness of breath from their breast cancers. But by putting them on an exercise program, they actually felt better. And not only did they feel better, but actually their pain levels went down. And their dyspnea, their shortness of breath went down as well. So for us, for a patient that says, oh, I can't exercise because I have some pain, now we have some data to say, what, why don't we try the right kind of exercise, because that can actually decrease your pain. Somebody that says, I'm kind of short of breath and so I can't exercise. Well, why don't we try the right exercise program, because that can help improve your shortness of breath. So to me, that was a wonderful study that showed that you all can do something about your health, and obviously we need to help guide you, and that works together with all the medications that we prescribe for the disease.
Awesome. Does the panel have any questions for each other? Anything you'd like to expound on? Any questions for one another before we open up to the audience?
I'd like to start by complimenting Virginia, not having to do with science, but in her role in helping to lead these programs that are bringing in a variety of topics, including things like imaging and radiation oncology.
It's a huge effort. That's a monumental effort.
Excellent.
So I want to ask guys, we had in the first day on Wednesday, we had 2 lectures on immune therapy in early stage breast cancer in patients with ER positive disease. And you weren't here, I wasn't here yesterday to get comments, but what are your thoughts about who we should be offering immune therapy in early stage hormone receptor positive breast cancer?
Yeah, I mean, that data was really compelling. And I think it was really encouraging for, both someone who on the research end is very interested in trying to identify who should get immunotherapy, and on the clinical end in terms of options that I have for patients. So I think previously, in terms of the hope that we can provide, previously immunotherapy was restricted to triple-negative breast cancer, patients with triple-negative breast cancer subtype. And we really were restricted to just one agent. And I think with the 7FL data and with the other keynote data, we suddenly have different options. Now, I think one of the things that I found most interesting was the efficacy in the ER less than 10%. You saw a really nice delta value there. And, it kind of lends the question of, how fluid are these subtypes? Are we really, when we define cancer, and especially breast cancer, by being around 3 subtypes, is that really all we can do, or can we break down our subtypes further? And I think you're starting to see that therapeutically. I think you're starting to see that with the ADCs. I think you're starting to see that with immunotherapy. And I think what we're realizing is that breast cancer can go beyond just these historic definitions. and really can be expanded out into better patient selection. But overall, I'm very encouraged by those results. Now, I think one of the questions that will remain is whether PathCR can be a surrogate. And I think if you kind of poll the field, you'll find very, very mixed responses in terms of what people believe whether or not that PathCR is a good surrogate. And I think we'll have to see how the data matures from there. But overall, I've been very encouraged as an immunotherapist.
And I have a question for David. We were talking about this a little bit earlier, but as an imager and a researcher in that area, lobular cancers are very hard to detect and to follow over time. We actually had a very interesting session on that, educational session on that. But the impression I got is that a lot of the imaging modalities in that area are still under study. And I just wanted to ask you where you thought things were in new imaging techniques for this type of cancer and where we may be going.
Yeah, lobular has a couple of issues which make it very sneaky. It tends to spread rather than in lumps, in thin lines that run along the ducts. And no matter what the imaging is, something that is not bulky but is a thin sheet or line is actually just, by the physics of it, very hard to detect. So these less cellular tumors are generally much harder to detect by just about whatever modality we're looking at. And we've got a couple of options. What looks the most interesting now for an agent that is approved for breast cancer, but not for early stage lobular breast cancer, is a tracer that is labeled estrogen. And the lobular breast cancers very reliably express high levels, at least in their early stages, of estrogen receptor. And some very preliminary data suggest that for staging, and I'm meaning more like regional nodal staging and distance staging, this looks very promising. And it's a PET agent with very similar characteristics to FDG, which is widely used in PET from a physics standpoint. But it looks at a completely different target, which is the estrogen receptor. And I think we're going to, in future years, there's a number of studies that are completing at single centers. We're designing multi-center trials that will be there. There are some other things that are a little bit earlier in the phase for that. There is a technique you'll hear about tomorrow that is somewhat blood flow based and has had some properties that may be helpful for lobular. There are also metabolic features that were presented at the Radiologic Society of North America, which is our imaging meeting right before this, whereas a labeled amino acid looks very promising for lobular based upon properties that have to do with its unique metabolism. So lots to come, but I think this estrogen receptor tracer, and again, I'm a consultant for GE who makes it, so I want to acknowledge my conflict. I think that looks very interesting in these early data.
Excellent.
Can I ask a question?
Sure,
Just
of course.
clinically, are you guys using that? Where are you guys using the PET-AVID, the estrogen, tracer?
We're starting a study with GE Healthcare that makes the estradiol that's labeled with F18, and we're going to look exactly at what David was mentioning. Can we actually improve staging both for early stage and advanced stage? Advanced stage is also a problem because the patterns of spread are unusual, the submucosal, peritoneal. Sometimes you can't even see it on a scan, but you see that the ureters are sort of shifted a little bit, so you presume that that's what's going on. And to see if it actually affects management. These studies are hard to do because the outcome measures are not simple, are you taking care of the tumor or not, but are you making better decisions? Because something might be better to visualize, but it may not help in the management. So we have to really look at it in a sort of holistic way. And then there's some newer imaging agents. He's the expert, but I'll just say in general terms that one can fashion, as David pointed out, radio avid materials or radioligands in some case for receptors that can allow not only imaging, but then you can use higher doses of radiation once you've determined that the lesion is avid, and then use a radioisotope that actually emits higher energy and heavier particles to actually give you a therapeutic effect.
That's the one time I get to play a real oncologist. I actually see patients for radioisotope therapy. It's been big in thyroid cancer, neuroendocrine tumors. Prostate cancer is actually for advanced prostate cancer. And I think for breast, there's so many other things that work well in the advanced setting that we haven't gone there yet, but I think we may come back. To answer your question, I'm actually involved in the early research for that tracer and was involved in the guidelines. I think the two areas that are most compelling right now are in those patients that are perhaps in second or third line choices about endocrine therapy, where you're wondering, did somehow this tumor lose the estrogen receptor? And are there sites of disease that lost the estrogen receptor, and can we use this imaging agent to tell us whether they exist, how to biopsy them? That's perhaps the most compelling data. Another area where there's a little bit less data, but we found it very useful in our own practice at Penn is, I'm sure you all run into these situations where you try to figure out where the disease is in somebody that's been treated for a while, and you go, oh my God, there's so much confusing information. And in ER-positive tumors, it can be a very helpful problem-solving situation, because if it still retains ER, this agent is quite specific for it. So a positive answer is very helpful, and it's almost like taking a biopsy in some ways. A negative answer just tells you you're back where you started from before, but at least you don't have estrogen receptor-positive breast cancer as a cause of what you're seeing. I think this is evolving. There was a lot of largely single-center data that supported this. We're just finished up an ECOG-ACRIN study in first-line estrogen receptor. We finished reading all the studies. Some of the people that read those studies are here with me today. And we hope to have this data hopefully out by ASCO.
Very exciting.
Yeah, and I think what both of you mentioned was, research. And I want to caution all of us, because we have patients coming in and asking for these scans, and we're not there yet, I don't think, in being able to recommend them as standard of care, because we want to finish this research and see how we can use them. Are they useful? And ultimately, are they helping our patients live longer? And I don't think we have that data yet. So I've been a little cautious in waiting for this research to complete, so that I can hopefully use these agents to help me make decisions on how to treat my patients.
And we have one other trial that's coming out that's using standard FDG PET called FEATURE. It's an ECOG-ACRIN trial. And it was designed because of the variability of the way people measure bone metastases. They use bone scan, they use FDG PET CT scans. This was really designed to be a prospective study to provide prospective evidence about the efficacy of serial FDG as a way to measure bone metastases, at least in those patients that have that. So that just finished accrual. It'll take a little bit while longer to analyze. So I'm hoping, sometimes we imagers aren't famous for producing clinical trials and the level of evidence that oncology are, but we're starting to change that, and some of these trials are now coming out.
Perfect.
Great. Okay. Thank our panel. Okay, at this point, I'd like to open up the floor to questions. Do we have any questions? It's hard to see with the light there.
Hi, no problem, Jason.
And if I could ask you to state your name and your organization, if affiliated with one.
For sure, would be happy to. My name is Heather Porowski. I am board member for the IBC Research Foundation and project lead graduate. And earlier today was the People's Choice session, which was about inflammatory breast cancer, which was awesome. So we're excited to see that. And I have kind of two questions or kind of takeaways to get your input. All of the panelists, oncologists, if you will, spoke about how important images, pictures, are to diagnose inflammatory breast cancer. And these aren't images on the mammogram. These are just actual pictures. And I wanted to bring that up to the advocates in the room, because actually that ended up saving my life, because when I went and was not diagnosed with inflammatory breast cancer. So there's different diagnostic tools that are happening. So I'm excited to see that. But it was because I had a picture of my breasts that I was able to text my new oncologist that's how she was able to pinpoint me to being IBC. So I just wanted to bring that to the forum to say, take pictures of your boobs, ladies, before you do anything. Hopefully I can concur with that. My second real question really is, like those with brain mets, those of us that are surviving with inflammatory breast cancer are kicked off of trials. We are not, and these are not like trials for pharma, these are trials for weight loss, exercise, osteoporosis, all the bones. So what I would like to know is that if you can speak to us advocates on how we can include these rare diseases in those type of trials and beyond.
Very good question.
Well, I can maybe take a start on that. First of all, thank you for your comments, because we need to promote awareness about inflammatory breast cancer. It is not a common form of breast cancer, but it's one that can progress quickly and needs to be identified as such, and needs the appropriate evaluation and treatment. Because there are certain ways that it does need to be treated and diagnosed. It's a difficult diagnosis because there isn't a definitive test for it. It's a clinical diagnosis, which means the clinical characteristics, which is why the pictures are important, what the breast looks like, the edema that the breast has, the rapidity with which it may develops over time, and the treatments have to be done appropriately. The surgical approaches are different, you make a really good point about some of the medical therapies we use, because those we do use similar therapies, but a little more aggressively in terms of like when we use chemotherapy. And so it's really important that we develop the right diagnostic tools, though, but that we also not only empower patients to know about inflammatory breast cancer, but more importantly, physicians. Because it is rare and not everyone knows how to treat it, yet people all over the country get it. And there are some specialized centers for inflammatory breast cancer, but not very many of them. And then the final thing, we should be developing not only trials that are specific for IBC. We're fortunate at our center to have one of a center that's dedicated, and we have those trials, but we should also expand inclusion of other trials for IBC. Most of them can be adapted. Now, there's some that really might not be feasible or possible, but we should really make every effort to be more inclusive with our clinical trials. And I say that as a general statement, too. I think we tend to be too restrictive because we're afraid the results may not be reliable, and we all have to be mindful of that when we design these studies.
And honestly, the reason why now patients with brain metastases are included in trials more and more is because the advocates complained. So this is where, and thank you. So this is where your voice needs to be heard, because this is how we change what our standards in our brains are.
And thank you for that. And and please remember IBC brain mets for any clinical trial. Thank you.
Thank you. So we've got a question that's come in from our live stream audience, a question on breast cancer cell senescence. Thoughts on whether we should do research on waking them up and killing them, or should we try and find pathways to block to keep them asleep?
Well, so senescence is an interesting phenomena, and there's a form of senescence that is known as dormancy, which we believe is why it explains the fact that some patients with breast cancer can develop recurrences 10, 15, 20, 30 years later. And we don't know very much about these senescent cells or dormant cells because they're microscopic and you can't see them, you can't image them. In fact, it was controversial that they even existed, but it was really from a theoretical standpoint that we assumed that senescence and dormancy is a thing, because mathematically you cannot have an actively dividing cell that relapses that far later. And finally, they've developed sophisticated animal models where you can actually visualize dormant cells using immunofluorescence and other technologies. So what reawakens these senescent cells is not known. That's a big area that needs to be studied. So to answer your question, I'd say you want to leave them dormant. You don't want to wake them up and kill them. Now, it is true, when they wake up, they may be more susceptible to chemotherapy, but I think they still are going to lead to a recurrence at some point until we get better drugs. So I think we want to learn how not to wake them up. And so far, the leading thinkers in this area feel that it has to do with inflammation pathways that leads to reawakening of senescence. But we don't really know much about that. And then there's a lot of people that are doing really elegant research on how to address that. There's a group at Penn, Angie DeMichel, who's got a project looking at hydroxychloroquine and palbociclib, I think, to treat dormant cells. And so there is some work going on in that area.
I'll just add to that. I think one of the areas that we really need to develop to understand senescence and dormancy is the preclinical models. I think, while we have a lot of preclinical models that can capture the phenomenon of senescence and dormancy, how much of that translates, in terms of targets, in terms of therapeutic strategies, I think it's, very tough because, what we're finding is that while we on the preclinical side and the laboratory side, we'd like to say, these mouse models or these cell culture models, they accurately represent what's going on in the human. They don't really. And one of the things that we lose in those models is the temporal nature of cancer. And so I think it's going to be a little tough to understand how we can directly translate what we're finding and understanding on the preclinical side in terms of modeling senescence and what actually translates therapeutically. Now, I'll say another thing that was kind of interesting to me, and there's been a lot of work on this on the NK cell side. So there's specific immune cells that my lab and other lab studies called natural killer cells that actually seem to be targeting these senescent cells. And so maybe there's potential for not just chemotherapy or kind of palbociclib CDK4/6 strategies, but potential immunotherapies that could be used as well. So.
Great. Okay. Next question from the audience.
Hi, Christine Hauser from the Lobular Breast Cancer Alliance, a patient advocate, but I'm also a physician myself. My question was on the antibody-drug conjugates. As far as I know, I haven't seen any studies that have separated out lobular and the impact that the ADCs have with lobular. And the reason I was particularly questioning that is that, as you were mentioning, the growth pattern is kind of so strange with lobular. So while the bystander effect, where the drug takes out nearby cells, is thought to be mostly an asset, I'm wondering for a patient who, say, has gut infiltration with lobular, would we potentially see more negative side effects because of the bystander effect, or whether there's any data on that or clinical experience?
I can comment on some of that work, but we just don't have data with ADCs yet. We do have data with standard chemotherapy. We've looked at that at our institution and separated out lobulars from infiltrating ductal cancers. The research in this area is difficult because lobular cancers are just not as common. But they're not that rare either. They're in the 5 to 10, maybe 15% range, depends on how you define them. And then there's mixtures. We have mixed ductal and lobular cancer, so we don't know how to classify them quite yet. We know that with standard chemotherapy, the response rates do tend to be lower, but they're not zero. For example, in early stage breast cancer, the complete pathologic response rates for lobular cancers are lower than they are for ductal cancers. But keep in mind that most of the lobular cancers are hormone receptor positive, so they tend to have lower pathologic complete response rates. Now, to answer your question about these sites where lobular cancers tend to go, like in the submucosal areas, in the peritoneum and the pleura, it's hard to predict what the bystander effect might be with the ADCs. And just to explain that, the bystander effect addresses the fact that these antibody-drug conjugates are taken into the cell, they're cell kill, and eventually they diffuse out of the cells, and there may be surrounding cells that then can also be killed by the chemotherapy that's attached to the antibody drug, because some of the cells may not express the antigen to which the antibody drug conjugate's attracted to. They're heterogeneous, something that we're recognizing more and more, and those might normally be spared from the chemotherapy, but because the antibody drug conjugate hangs around, it addresses those cells that have less of the antigen. So that's generally a good thing. So even though I can't answer your question, my supposition is that it's still helpful, because we want to get the drug out into the microenvironment and surrounding area where it'll address the cancer cells. Because chemotherapy drugs are more specific for cancer cells than normal cells, I feel that would still be a beneficial thing. Now, there may be some increased toxicities because there's still injury to the cells, right? So I think that when we do these studies, we have to be a little more careful. Normally, when we're testing a new drug, we do dose escalation to make sure that we're slowly, in sequential patients, picking up toxicities as early as we can without just giving a full dose. So I think these trials are going to need to be adapted to do that, depending on the antibody drug conjugate, to prevent injury, but to still maximize the potential benefit patients can get.
Thank you.
Thank you. All right, next question.
Hi, I'm Amy Parliament from Surviving Breast Cancer, and I have a question for Dr. Mankoff. So in your studies, do you feel that patients that have been on hormone suppressants for years, does it affect the results for the metabolic activity for the Cerianna PETs? Can you get accurate results from those studies if you've been on it? Because we know we have to come off of some of those drugs, but they're still circulating in our system.
Yeah, it's a complex question, and we don't have all of the answers to it. For the standard PET scan, which is FDG, a glucose PET scan, it's pretty clear that treatment will affect and reduce glucose consumption in successful treatments, including things like chemotherapy and endocrine therapy. Exactly what that means from the standpoint of detection is hard to know, and it may be that we suppress some treated disease on some of those areas. The other thing that may be happening is the complexity of this new estrogen receptor imaging agent is that those agents that block the receptor, like tamoxifen or fulvestrant, get in the way. And so there's been a challenge there in figuring out if you want to use that type of imaging and you've been on one of the agents, you'd have to wait a while and come off of that agent before you get re-imaged. I don't think we've solved that particular problem, and it's unique to this relatively recently approved and early agent. But in general, for the standard PET scanning we do, we don't necessarily recommend that you come off of your therapy because the absence of FDG uptake is generally associated with a favorable prognosis and generally associated with something that's working, especially if it started to be hot. So the idea there is if we're restaging you with that study and all of a sudden you had areas that were not seen by a PET scan and they are now seen by a PET scan, that probably needs to be confirmed by other imaging modalities and sometimes biopsy, but that's usually an indication that you are progressing on your disease. I don't think it would make sense to come off your treatment in any of those cases just to be able to detect disease that may be functionally treated but still is not completely dead. And it's an important point with any of these imaging studies, we can often tell whether things get better or worse. We have a lot of trouble telling with most modalities whether there is treated residual small volume disease because we often don't pick that up. But as long as it doesn't get worse on the scans in many cases, that can be a very effective way of monitoring the treatment.
Okay, can I ask a second question?
Sure.
So if we've had an FDG PET and then we want to have a Cerianna PET, can those two be compared to each other or do they look different? And if so, does the doctor need to be trained to read the Cerianna PET?
Yeah, so first of all, I want to just emphasize what Virginia said, is we're relatively early in our clinical experience with the Cerianna, the fluorestradiol PET. They are very different, and as a matter of fact, I often advocate that you have the two of them together to read, because the most important thing you're going to find from, I think one of the most important things you're going to find from the Cerianna, the FES PET, is that your estrogen receptor has lost, your tumor has lost the estrogen receptor, which you can detect in direct biopsy. It's very tough to tell what you're missing. And in the cases where the tumor has lost the estrogen receptor, it almost always will have increased glucose consumption. So there's the ability to be able to do that. There is a need to train people on how to read the fluorestradiol PETs. They're very similar to FDG in some ways, but there's very different ways of reading. And there are actually strong programs coming out through a variety of organizations, including the Society of Nuclear Medicine, to do that. But if you're looking to get one of those tests, and I want to echo what Virginia said before, make sure the team is familiar with it, that it's being used in an appropriate fashion that's evolving, and make sure that it is being done and interpreted in conjunction with the ordering physician, usually an oncologist who interpret it, because these things can never be taken out of context of the clinical scenario.
Thank you.
But thanks for asking about that.
Thank
It's
you.
a rapidly evolving situation.
Okay, next question.
Hi, Kelsey Litwin with the Breasties. I wanted to follow up on this new exciting research around the benefits that exercise can have for patients living with metastatic disease. What I was particularly interested in with that study was the role of supervised exercise compared to general exercise advice. And I wanted to know from all of you, what should our next steps be to ensure that patients have access to that supervised exercise?
Great question. Virginia, you want to tackle that?
Yeah, so this is where resources are extremely important. It's, we know actually part of what I didn't talk about with exercise helped everything except for one thing, psychological benefit. And so the presenter said, it's great, but if you have somebody that needs psychological assistance, please send them to a specialist and don't rely on exercise. So now when we're talking about support for our patients, we know that they need exercise. We know that they may need a mental health professional. We know they may need a dietitian. They typically need a social worker, and they may need a navigator. So I think I mentioned 5 individuals, and now we need resources for all those 5 individuals. So this gets practically a little hard, and that's why what we need to work on is something that can be adaptable to our patients. Our patients with metastatic disease, many of them have bone metastases. And so telling them to go on some sort of program that is high impact may actually cause fractures. So we can't, it's not a one-size-fits-all model. But this is what we need to work on because we all know that our resources are limited. And I don't think that every place in the world will have 5 individuals for every single patient to help them through their journey.
Thank you.
Okay, next question.
This is not my question. However, I think it'd be a great idea if the pharmaceutical industry lowered their prices and the money was used to pay for the extra services.
It would.
I'm Ann Fonfa, the founder of the Annie Appleseed Project. Our focus has been on the harms, and it still is, and it always will be until those harms are paid attention. Today, I listened to the talk on sentinel node. I heard Monica Morrow for the 400th time talk about how it's really not necessary. I think lymph nodes are meant to do what they're doing, catching cancer. We need our lymph systems. I've had lymphedema for 32 years. Sucks. Okay. But the harms are very important, and we don't pay enough attention. Even when it's mentioned, it doesn't mean anything. We're not doing anything about it. We're just talking about it. So I urge everyone to consider making a difference. I favor the simple, natural things like exercise, like nutrition, like stress reduction. And by the way, my husband, who's a champion athlete, believes that exercise is as important for your brain and mental health as anything else.
Hi there. I am a radiation oncologist from MD Anderson, Liz Bloom. So I just wanted to, since this is about patient advocacy and a follow-up to harm, for these small early stage breast cancer, small ER positive, node negative, it was really interesting data presented today showing low local recurrence rates using Oncotype DX and just using endocrine therapy alone without radiation. However, there's a flipped side to that question is now with radiation shrinking their fields for those small, tiny tumors and doing it over 5 days, would that be a better choice than 5 years of endocrine therapy that can cause hot flashes, bone loss, mental issues such as depression? And the question isn't answered yet. And there is an open study, not in the US, to ask that question. But before we don't refer to those small ER positive between 50 and 69-year-old patients to the radiation oncologist, I think a full discussion is indicated because we know that up to 30% of patients don't complete the 5 years of endocrine therapy, and then the recurrence rates do go up. So don't write off radiation, have the discussion. Thanks.
Thank you. Any comments on that last question?
I'll comment, and I want to thank you for this. And you know, I think about this a lot for our patients that have ductal carcinoma in situ, DCIS. And there's a nice model that I've started using from Memorial Sloan Kettering that calculates not only the benefit from radiation, but the benefit from endocrine therapy. And the more I use that model, the more I realize that my giving a patient 5 years of endocrine therapy decreases their risk of either the DCIS coming back or them getting invasive breast cancer by a couple percentage points. And is it really worth giving a therapy for 5 years for that, that 2 or 3 percentage points? And I really don't think it does. And if you look at how our studies were done, they were done looking at radiation, but they weren't done comparing radiation to endocrine therapy. And to me, it's so much easier to give something for 5 days or 3 weeks than giving something for 5 years.
Yeah, absolutely. All right, next question.
Hi, I'm Sandy Feinstone from the Komen Foundation. Yesterday there was a session, a debate about anthracyclines. And it was great fun, and it was very inactive, and there was a lot of really good information, both pro and con in that area. At the end of the session, the moderator asked the audience some questions and asked them to respond. And I don't know if any of you were in that session, but for me, the results of those questions was quite startling. Anthracycline, yes. Everything else, no. Next question. Anthracycline, yes. Everything else, no. And it was almost as if those researchers in the room were not listening to the debate. Can you comment on that? Because I think everyone in this room would say anthracyclines, no.
Good question.
Well, I think really it's a matter of what you get out of the treatment. You're right that anthracycline versus non-anthracycline therapy has a lot of differences in terms of side effects, not only the short-term side effects, but also some long-term side effects in terms of effects on the heart and even a small risk of leukemia. So you want to be at a point where, but anthracyclines are more effective, but only for higher risk breast cancers. And so the studies that have compared anthracycline to non-anthracycline show like a 2 or 3% difference in the recurrence rates, which is actually around the risk of having a long-term cardiac toxicity, but I don't think we still know the point at which to define that. I think anthracyclines should be reserved for high-risk breast cancer, multiple positive nodes, triple negative breast cancers, and inflammatory breast cancer. That's when we tend to use them.
Yeah, and I would add that I don't think, and I think Dabu and I practice similarly, that HER2-positive breast cancer is really one subtype that we've successfully avoided anthracyclines, even in our high-risk patients.
Again, I know I'm repeating myself, but the thing was the response from the audience. It was just so overwhelming. It was like this wonderful discussion and no movement in that arena. Thank you.
Next question.
Thank you. My name is Naomi John. I'm here on behalf of the Inflammatory Breast Cancer Network in the UK. I'm encouraged by what you've just said. Anthracyclines, absolutely yes for IBC. My point is more of a comment rather than a question. So the discussions that have taken place throughout the conference as regards to exercise programs, I was really fortunate to take part in an exercise program that was funded through Cancer Research UK and the University of Southampton. That trial is called SafeFit. The results haven't been published yet, but I was assigned a PT. Everything was remote because this was during the COVID pandemic. It was a really good example of supporting patients remotely and enabling them to exercise within their own home. But my comment is on the maintenance of that afterwards. So during my treatment, my PT was able to adapt depending on what my side effects were. I had a high-grade hand-foot syndrome, so we were able to avoid anything that involved my hands and my feet. But like I said, the maintenance of that afterwards, that has to be delivered with psychological support so that you're really encouraged and motivated to keep that going afterwards because it's a lifestyle choice.
You're absolutely correct. It's actually interesting. I reviewed a study a few years ago. It was done in Alabama. And they took breast cancer survivors. And their goal was to help them develop a vegetable garden. And half of the women were given brochures and said, please go and develop the garden. And the other half actually had trained professionals showing them how to do this. And as you can imagine, the group that had the trained professionals did better and actually did the vegetable gardens. And that's great, but that wasn't just what they saw. They saw that these women changed their diets because now they had a vegetable garden, so I started eating more vegetables. Their family changed their diets and were eating more vegetables, because who's cooking typically? It's the woman. And after the study was over, they followed them for another 18 months. And the majority of those women continued maintaining that vegetable garden. It increased their exercise. And so all of these benefits from something not extremely complicated, and to me, a lifestyle change, because ultimately we can go on some crazy diets and we can go on some crazy exercise programs, but can you maintain that over the long run? And most of us cannot. And so it was a lifetime change that was able to be maintained over time. So I think obviously we all have to help ourselves, because it's not easy for other people to be helping us. But the way I would look at all of this is that we do have to see it as a lifetime change, lifestyle change, not just, I need to go on this exercise program. How do I change my whole life around this so that my life fits into this and this fits into my life?
And I think it's challenging afterwards, in the years that come afterwards, with the kind of far-reaching effects of radiotherapy, of chemotherapy. Fatigue kicks in when you're least expecting it. You get lymphedema side effects. There's always a reason why we don't do something, and we've just got to grab it and go for it.
Mm-hmm. Thank you. Okay, next question.
Hi, my name is Bev Salzman-Lewin. I'm from Atlanta, and I created a website called the Bev Strategy. I used to be in charge of research for CNN's National Desk, and during that amygdala hijack that everyone experiences after they get a diagnosis, our brains don't work well. It's very hard to internalize what we're hearing, to think, and to learn. So it's just a nonprofit website for patients to help them navigate that post-diagnosis chaos. But my question, and forgive me if I seem naive, this is my second San Antonio Breast Symposium, and then I was also at ASCO. And the thing that really strikes me about it all is just how little there is at these conferences that I've been to so far that is not completely pharmaceutical based. And as a patient, I've actually had 3 cancers, breast being one of them. There's so much power in the lifestyle choices and the things that patients can do to support themselves both during treatment and prevention. And it's just dismaying to me, and I don't fully understand it. I know you follow the money, and the sponsors of studies are the pharmaceutical companies, but I know physicians go into this to cure people and support them. So I just wanted to ask for
It's a question I think
thoughts.
many of us have. What are y'all's comments on that?
I don't think that there's, I'm going to use the flip side. If you look at the maps in the United States for the past 20 or 30 years of obesity, and you can look at them, the CDC has this amazing maps on obesity and how they change over time. You're going to see that our society is becoming more and more obese. And this is something that we haven't been able to change, even though everybody knows that they're supposed to exercise and everybody knows they're supposed to eat well and everybody knows what eating well means. And most people know what exercise is. And so we have failed as a society. And I'm not going to blame physicians only. I'm going to blame me as a person, and I'm going to blame all of us as people for not being able to take care of ourselves. And so to us, it's much easier when a patient comes in to say, well, here's a medication you can take. And I can tell you that there's data suggesting that exercising and maintaining a healthy weight in early stage breast cancer improves benefit as much as chemotherapy does. But I can prescribe chemotherapy, and in 5 minutes it's in my system and signed. And if I tell a patient that they need to lose 20 pounds and they need to exercise 5 days a week, the chance of them doing that is close to zero. And even though I send them to a dietitian, and even though I explain what exercise means, they just won't follow that. And this is, I think, our society. I think we've become complacent, and that's something that we all need to understand and see how we can fix. So you're right, we're not doing enough, but I don't think necessarily that we are not doing enough. I think we all are not doing enough.
Thank you.
Thank you.
We have time for probably one, maybe two more questions. But next up.
This one is related to what you were just asking. I just wanted to kind of add the comment that I do think the lifestyle issues, are a very big factor in so much of healthcare, whether it's breast cancer or other topics. But I do think also that is a difficult thing for most physicians who are in other fields and so on. They don't have a lot of expertise. They don't have a lot of support either for doing that. So I would also encourage patients or perhaps oncologists to form alliances with doctors who are boarded. We have a medical board now from the American College of Lifestyle Medicine. So to seek out the physicians who have actually chosen to do that certification and have that background, because they're going to be much more equipped to take care of that, so the oncologist can kind of do their thing primarily and then switch to somebody for lifestyle medicine who's expert there. Yeah.
Thank you. Next question.
Hi, my name is Sarah. I guess I want to know how you're thinking about some of the inequities and problems that come about in the way we talk about obesity and the way we don't think about, I often feel like we don't talk about the structural factors and the health inequities that come around from things like lack of food access, all the different kinds of structural factors that shape that. And also, I think, I get very nervous about the way we talk about obesity because of the way many of us gain weight on these drugs and the way many of us were very, very healthy. And I personally am constantly asked, what do I think I ate that gave me stage 4 cancer in my 30s? And so I'm wondering how you're navigating thinking about and communicating to patients things like the exercise program while attentive to structural factors and also sort of some of the popular public discourses patients have to navigate.
Thank you for that. I think this is a question on a lot of topics, so I'll try to address as many as I can. First of all, diet and exercise and breast cancer. We have yet to find an association between a specific kind of diet and an increased risk of breast cancer. And we actually have some data that in premenopausal women, obesity does not increase the risk of breast cancer and actually may even be somehow protective. In postmenopausal women, we know that obesity increases the risk of breast cancer by a little bit. But the other thing that we have failed to do is in women that have been diagnosed with breast cancer, we know that exercising and maintaining a healthy weight helps, but we have yet to find a diet that is better than any other diet in decreasing the risk of recurrence. So if I tell you that you should adhere by the Mediterranean diet, and there was a recent study looking at the Mediterranean diet, and that'll help you even more, the answer is I can't prove that to you. So if you say, I want to eat candy all day long, but I'm going to lose weight because I'm going to eat 500 calories of candy, I'll say, please go ahead and do that. Because as long as you maintain a healthy weight, that's all the data that I have. Now, you're right, and that's the other, again, the flip of the coin. What are we doing to you with our treatments that is either making you gain weight or preventing you from losing weight? And unfortunately, we're doing a lot of things to you. We're putting you into menopause at the age of 30 or 35, and menopause increases weight gain and decreases your basal metabolism, makes it hard for you to lose weight. We're also giving you chemotherapy, and we're giving you other medications and steroids that also make you gain weight. And so what we're doing is we're telling you, yeah, you should lose weight, but here's all these medications that are going to make you gain weight, and good luck with that. So this is something that we all need to work on. And there's no simple answer. It's a lot of hard work. And what I typically tell my patients is don't get discouraged, because yes, it is a lot of hard work, and it's going to take you longer, and it'll be harder for you to lose weight than somebody that hasn't been on these drugs and is not on these drugs and is premenopausal. But that's something that we all need to work on. And we now have some medications that actually seem to help with weight loss, and we're going to be studying them in breast cancer and seeing how safe they are. And the other thing that you mentioned, I think, has really nothing to do with breast cancer itself, but it has to do with all of us, of how do we all eat healthy when the unhealthy food is actually really cheap and the healthy food is really expensive. And that's, I think, one of the reasons why we're seeing all of these rates of obesity going up, because if you go to the store and you have $3 to eat, you're more likely to buy junk, because then you can actually eat something. Whereas if you try to buy some organic product, you're going to pay a lot more than $3.
Great.
Thank you.
Thank you. Well, unfortunately, we're up against a hard stop for our live stream here, so we're going to have to conclude the evening. Want to give a round of applause to our panel. Dr. Kakhlamani, Dr. Chan, Dr. Menkoff, Dr. Tripathi, thank you so much. We really appreciate you spending your evening with us, and hope we all learned a lot tonight. Thank you again. Once again, as we close the program here, I'd like to thank our sponsors, our volunteers, our committee, everyone involved in this program, and most importantly, thank all of you for joining us tonight. Thanks again.